Hello, everyone. I am Michelle Kahlenberg from the University of Michigan, and I am delighted to be here today to discuss the biology and treatment of lupus flares. These are my disclosures. And the biggest disclosure is that 20 minutes is tough to go through the biology of lupus and how to treat it, but I will do my best to keep this focused on the most salient points. I did include some additional resources here if people want to read more on this topic. Here are some excellent articles to check it out. So to start, I thought I would remind us about the cycle of lupus. So we think that lupus initiates from genetic predisposition that interacts with environmental triggers. And over time, this results in innate immune activation that then educates our adaptive immune system to promote the development of autoreactive B and T cells. And these B and T cells, the B cells contribute to immune autoantibodies, and these can lead to immune complex formation, which can then deposit in the tissue. And we may not see disease initially, but the cycle can repeat, and eventually we will get to clinical disease onset. And one of the things to remember is that the presence of these autoantibodies often occurs way before a patient ever presents with a phenotype that looks like lupus. And so really having the autoantibodies themselves isn't enough to actually cause lupus, and it's probably this interaction with the environment over time that promotes and drives the actual presentation of disease. So when we think about a lupus flare, we know that about 25% of patients per year will have a flare of their disease. And how we quantify this, I think, is up for debate. There's several different ways you can measure disease activity in lupus, including looking at the selena slidi or the BILAG, and there's flare definitions within each of these metrics. There's the selena slidi flare index. But for me, I think the most useful definition of a flare is really, does the patient feel worse? And do they feel worse because it's their lupus? And so one of the things as clinicians that we have to do is really figure out if their change in symptoms is related to lupus itself, or whether there are other diseases that can be contributing to them feeling poorly. And I think fibromyalgia is one that we often see overlapping with lupus. And so is there complaints of pain or fatigue more related to a fibromyalgia type reason than active lupus? Stress is certainly a known trigger for lupus flares, but being stressed out can also make people feel more pain, sleep poorly, in general feel terrible. So this could be a contributor or mimic. Infection is definitely one that can cause symptoms that can look like a lupus flare. Lack of sleep, when patients don't sleep, they feel worse. And so sometimes they can have pain and other symptoms like worsening fatigue that could be because of poor sleep instead of their active lupus. Also, other treatable medical issues like iron deficiency, vitamin D deficiency, concomitant autoimmune diseases like celiac or hypothyroidism. These things can all make patients feel terrible. And so, as rheumatologists, one of the things that we pride ourselves on being really good at is investigating and understanding, all of the systems that can be involved in autoimmune disease, but that can also contribute to a patient feeling unwell. So if we do our detective work and we decide that a patient actually does have increased lupus activity, what do we do once we reach that conclusion? And I think the most important thing for us to really figure out how to properly treat our patients is to understand the underpinnings of lupus, to really know which drug we need to pick. And so I'm going to try to talk about the biology of lupus and lupus flares in about 5 slides. We'll see. So I think the first thing to remember is that lupus flares require a trigger. There's usually something that pushes people over the edge. And the reason that these triggers actually can cause a lupus flare is really the interaction with the innate immune system. So a lot of the known triggers for lupus, like sunlight, infection, stress, diet, these all have impacts on the macrophages and dendritic cells that are living in the tissues of these patients. And these macrophages and dendritic cells then make pro-inflammatory cytokines, and they also present antigen to T cells and can turn them on and activate T cells. The other thing is that if you already have some autoantibodies floating around and you get some immune complexes formed, even if you don't feel sick, these immune complexes can also activate our macrophages and dendritic cells and turn them on and sort of start this flare process as well. And then again, the downstream consequence of these macrophages and dendritic cells getting turned on is the activation of B and T cells. So I always feel that the innate immune system is really important in initiating the trigger of a flare. The second point, I think, is that type 1 interferons are really a unique lupus feature that impacts disease. And this is some older data shown here, where they just looked at how much type 1 interferon bioactivity is in the serum of patients with different autoimmune diseases, including lupus, Sjogren's syndrome, and scleroderma. And you can see compared to healthy control, you do see some interferon activity in Sjogren's and scleroderma, but really lupus takes the cake. And we see a lot of patients with circulating interferon signatures and increased interferon production. And these interferons come from both, the innate immune cells in our body, macrophages, dendritic cells, plasmacytoid dendritic cells, but also are produced by the tissue. So the keratinocytes, for example, in the skin are very good at producing type 1 interferons. And these interferons are driven by what we know cause lupus flares, like UV, viruses, and bacteria. And the reason that these interferons are important is because they cause widespread changes to the immune system. And they do things like making our dendritic cells more active to present antigen to our T cells. They increase class switching of our B cells and get them to make more antibodies. They repress the negative regulators in our immune system, like the Tregs, and keep them from turning off inflammation when it gets started. And they're also really important in driving the development of lupus rashes. So the interferons are kind of a unique thing that get turned on sort of simultaneously with these triggers, and they really impact both the innate and the adaptive immune system. And I think when we think about the biology of how we treat lupus flares, one of the things that's very cool about treating lupus now is that we have a drug that can block interferon signaling called anifrolumab. And this is just data from one of the trials for anifrolumab that shows that patients who were on anifrolumab actually had fewer flares while they were on treatment. And so, again, the type 1 interferon activation may also be playing a role in activating this whole flare process. And really, I put this here as a pro tip because right now we still don't have a very accessible way to test for high interferons in lupus patients, but you can get clues just from lupus patient phenotypes. So if they have a lot of antibodies to RNA proteins like Smith RNP, Rho, La, they tend to have a higher interferon signature in general when they carry these autoantibodies. Patients who are refractory to Plaquenil often have more interferon circulating. Patients who have very low lymphocyte counts often have a higher interferon presence as well. And then again, patients with skin disease often have a very robust interferon signature, both in the skin and in the circulating blood. So if you're thinking about what patients to give anifrolumab to, and you don't have a test for looking for interferons, and someday we may, this is one way to kind of decide if the patient might benefit from something like anifrolumab. So the third point I want to raise is that T cells are important, but aren't the only player in lupus flares. I think 15 years ago, we were very T cell centric in lupus. And now we know that the innate immune system also plays an important role. But some of the things that happen in lupus with the T cells is that we really don't have very good regulatory T cells in lupus patients. So we don't have this off switch to turn off the inflammation. And there's been trials that have tried to turn this on. So far, we haven't been able to to get this to work yet. We also know that the T cells are more activated in lupus patients, and this provides B cell help, which allows for B cells to mature and class switch and make more autoantibodies. We also know that in lupus, there's increased cytotoxic T cells in the organs of patients, and this causes cell killing and tissue damage. So if we think that a patient's having a flare and that the T cells are activated, drugs like methotrexate and Cellcept are really good at coming in and stopping the replication and activation of T cells. The fourth thing I wanted to discuss is that B cell activation is really important in many patients. And we develop autoreactive B cells for several reasons. But one of the reasons that our B cells can escape negative selection is that there's a protein called BAFF that allows for B cells to survive even if they're recognizing autoantigen during the selection process. And in healthy people, the BAFF levels are pretty low. And in lupus, we know that the BAFF levels go really high. And actually, as an aside, the interferons actually can make those BAFF levels go up. So if you have a lot of BAFF floating around and you are trying to delete an autoreactive B cell during its development, you will override that death signal through the signaling through the BAFF receptor, and you actually will let those B cells survive. So as you likely know, we now have a drug that blocks BAFF called belimumab, and belimumab is one of the things that it does is it prevents this survival of these autoreactive B cells. And also, if we look at the developmental pathway of B cells in general, you can see that the BAFF signaling is important in these very early B cell stage development. And once patients get once the B cells get to a more mature stage, the BAFF plays less of a role in the activation or maturation of these cells. And so I think another pro tip is that you really, when you give a patient belimumab, it takes a long time to work because it's not eliminating the cells that are currently making autoantibodies, but rather it's working on preventing the development of these autoreactive cells early on. So oftentimes, if you're treating a flare and you're thinking about adding belimumab, you really need to add in a quicker acting medicine with the belimumab in order to shut off the active part of the immune system and then wait for the belimumab to work by preventing the development of these cells down the road. So steroids plus belimumab can be a combination that you can think about. And B cell active, so I have a second slide here. I'm kind of breaking my 5-slide rule, but I wanted to also emphasize that the autoreactive B cells that turn into antibody secreting cells, there's actually different antibody secreting cells that contribute to different types of autoantibodies. So you may have heard about plasmablasts, which are sort of rapidly made after a naive B cell gets activated. It turns out that plasmablasts, or sometimes you'll hear them called short-lived plasmablasts, are actually really good at making anti-DNA antibodies, and also antibodies that bind the mDNA or the NMDA receptor, these antibodies can activate complement and cause immune complex deposition in tissues. But because more of the DNA antibodies are coming from this, if you use a drug that targets a plasmablast, you might have a better impact on these types of antibodies. Now, the RNA antibodies come from long-lived plasma cells. So if you're using a drug that doesn't deplete a long-lived plasma cell, but the disease is being driven by anti-RNA focused autoantibodies, you might not get as much of a treatment benefit from that. And so if you think about another pro tip for treating lupus, belimumab actually probably has more effects on phenotypes that are coming from short-lived plasmablasts because it can affect the development and block the development of these plasmablasts. The long-lived plasma cells that stick around forever, they're not going to be killed off by belimumab. And so if you're targeting a disease related to antibodies produced by these long-lived plasma cells, belimumab might not be the best drug to choose for that patient. The other thing to remember is that rituximab also doesn't deplete most plasma cells. And so again, if you've got a patient that you think is having trouble because they're making all these RNA antibodies and RNA-driven immune complexes, rituximab may not help here. But again, if they're having things driven by short-lived plasmablasts, then maybe Rituxan would be useful because it's going to help deplete those. And the other thing to remember is that coming down the pipeline, there's a lot of therapies in development that actually will take out both populations of these antibody secreting cells, including CAR T therapy. So CD19 CAR Ts will deplete populations of both of these groups. And so, that may be one of the reasons why, a more holistic B cell targeting therapy could be more effective. But for now, those are still in, the research space. And then the last piece about lupus biology and lupus flares that I wanted to highlight was that complement activation is an important part of how tissues become damaged in lupus. And so, we all maybe remember or maybe have to look up every time we think about it when we think about complement activation. But I think the important things to remember is that the reason this is important is because you get immune complexes in the kidney, which can activate the innate or the kidney, using the kidney as an example here, you can activate innate immune cells that are triggered by these immune complexes that build up in the organs. But also as complement is activated, it also produces chemotactic factors that can bring inflammatory cells into the organ. So it's not just the immune complex itself, but it's the activation of chemotactic signals that also contribute to disease. And we know that a lot of manifestations of lupus, including nephritis and skin disease and arthritis and CNS lupus and pleurisy and hemolytic anemia, they all have demonstrated roles for immune complexes in causing, destruction or disease in these various organs. And so immune complexes are important, and complement activation is part of that. And if you think about when the complement gets activated, one of the pro tips is the reason why we see a low C3 and C4 is because these C3 and C4s get cleaved as part of this complement activation pathway. And so if you measure the total C3 or C4, it's going to go down as these are getting cleaved into their byproducts. So that's why that test works when we're trying to see if a patient has disease activity. And I think the other thing that's up and coming is that we can also actually use activated complement components to help us better diagnose lupus and also look for evidence of disease flares. So as some of these complement proteins are activated, like C4, you get cleavage into several different parts, C4a, C4b, C4c, C4d, and we now have tests that will actually examine for C4d deposited on either immune cells, like B cells, or on erythrocytes. This erythrocyte-bound C4d and the B cell bound C4D have become part of some commercial testing. So one of these tests is called the AVISE test, and it does help us improve the specificity of just a positive ANA. So if you see these cell-bound complement products as part of this, you can actually have more confidence that something is actually happening and that you're turning on immune complex pathways. So I think if you're really questioning whether a patient is flaring or whether a patient actually has lupus, sometimes looking for these cell-bound complement products in addition to some of the other components like C3, C4, double-stranded, you can, kind of put a better total picture together for patients if you add these cell-bound complement products in. I don't do this on every patient, but ones where I'm really not sure if they have lupus or I'm really not sure if they're active, sometimes I'll do this as sort of a test to kind of give me a little bit more data to help me figure out if a patient is having a flare or not. So that's the biology of lupus and lupus flares in a very short amount of time. So I wanted to focus the last couple slides on just discussing how do we actually go about treating flares in patients. And so I think right now the most comprehensive place to get this in a very easy way is just the new EULAR 2023 lupus treatment recommendations that came out. And they break this down basically into non-renal and then renal flares. I just wanted to highlight that they do a nice job of reminding us that lupus isn't only treated with medications. We need to provide recommendations for sun protection, exercise. Quitting smoking is really important, especially for skin disease. Helping with diet, making sure patients are protected against infection, et cetera. And then if they have concomitant antiphospholipid antibody syndrome, thinking about aspirin or vitamin K antagonists as well. And then also if patients are flaring and you have them on good drugs, I think it's always wise to assess adherence to treatment. So I often send Plaquenil levels and mycophenolate levels in my patients if I'm not sure that they're taking their meds properly, because I don't want to say that they failed a certain drug if it really just was because they weren't taking the drug in the first place. So I think this is a really important thing to remember when patients come in with a disease flare. And, so our choices, basically hydroxychloroquine should be in every patient, right? We should use it unless there's a contraindication. Either they've had an allergy to it before or they've got bad retinal disease and you're worried about the risk of toxicity or something else. And then steroids, if needed, they really are our fastest acting drug. And if we're worried about, active ongoing organ damage, they really do shut the process down very quickly. And obviously we want to taper as soon as we can safely and try to get them below 5 milligrams a day as quickly as possible and hopefully off. And then I think, what you choose next really depends on the organ involved and sort of the patient phenotype. And the way I kind of think about this is if I have a disease where I think the T cells are active, and remember, again, these are in non-renal patients, I will go to either methotrexate. So sometimes for skin, for joints, sometimes for pleurisy, I think methotrexate is good. Imuran I kind of use as a third line agent. Cellcept I'll use again for kind of those same indications. Maybe if they've got, MMF, I didn't mean to call it by its brand name. So for MMF, if they've got hematologic issues ongoing, hemolytic anemia, those types of things, I think it can be useful. And then, who do I put on belimumab? I put people on belimumab if they have a lot of double-stranded DNA and low complement as part of their disease activity. I will put people on belimumab if they have a lot of fatigue complaints, because it actually does have data that it will help improve that. And also I'll use it as an adjunct, if we get partial disease remission with some of these other drugs, but not quite there, I'll add it on as another step. And then for anifrolumab, I think for skin disease, it really has been quite impressive in my clinic. And I think a lot of case reports coming out for refractory skin. There's been a lot of, I think, happiness among patients and physicians for anifrolumab and improving skin disease. How it performs in the rest of lupus, I think the data is a little less clear. If you go on the patient boards, they seem to like it. But I usually tend to save anifrolumab for my really refractory skin patients, unless I've sort of run out of other options and then I try it. So that's kind of how I approach the use of that. And then again, you can add in things like calcineurin inhibitors. We really don't jump to Cytoxan or rituximab until they have severe non-renal lupus. So, horrible hemolytic anemia. I think that works really well with Rituxan. Really, really severe skin. I think cyclophosphamide is our standard choice still for neuropsychiatric lupus. So I think, again, thinking about what they're presenting with, what their flare symptoms are, and then picking the medication across this to sort of best match up what you think will work. And then for treatment of lupus nephritis, again, assessing adherence to treatment if they're flaring. And then again, remembering the accessory treatments that go along with treating lupus nephritis, like making sure they're on an ACE inhibitor, especially if they have a lot of proteinuria, considering an SGLT2I. There especially if they have a low GFR. And then again, if they've got committed APS, to make sure they get anticoagulated as part of this. And then again, hydroxychloroquine should be for every patient. If they have a low creatinine, you may need to adjust the amount of hydroxychloroquine you're giving them, and you can check a level, make sure you're not overdoing it. But everyone should be on hydroxychloroquine if you can. And then again, IV steroids, I think we're starting to give less IV steroids. So now the recommendation is about a 0.5 mg per kg per day, pulsing, and then tapering as fast as you can, again, to 5 or less. And most people now for a renal flare, if they don't have a reason not to, will start with MMF because of oral dosing, less toxicity with, IV Cytoxin. But starting with MMF and titrating up to full dose and hopefully seeing some response. If a patient's really severe, has very severe proteinuria, you can consider adding on a concomitant calcineurin inhibitor or adding belimumab. And if they can't tolerate MMF, then we look at either low-dose cyclophosphamide. If they have a really high creatinine or very rapid progressive disease, you can also argue you should do low-dose cyclophosphamide up front because MMF takes longer to work. And you can consider high-dose Cytoxin. We tend to do this in patients who are overweight because we've found some data that if you are heavier, you may not respond as well. This might not be enough Cytoxin when you're getting the low-dose Lupus protocol. And so you might want to consider weight-based dosing at that point. Or if they have rapidly progressive, very aggressive looking crescentic disease on biopsy, then also you would maybe want to consider just going with the higher dose cyclophosphamide protocol. And again, with failure, you can always add in rituximab. Sometimes if patients seem to be pretty refractory, this is still an option. And, this will change again. There's more drugs being studied. And so I think these types of graphs and outlines are really helpful to come back to when you're really thinking about what to do with your patients. So I'd like to end with just some patient examples for which you guys can vote, and we'll kind of just talk about treatments. So for these patient examples, assume that they're on hydroxychloroquine and we've already checked and they're compliant. And you can assume that we're going to add some dose of steroids. When I say what would you treat them with next, just assume that steroid will probably be part of the management. So this is the first patient. She's a 40-year-old female, has a 20-year history of systemic lupus that's been characterized by arthritis and skin disease predominantly. She gets a diffuse discoid rash. She gets pretty profound hair loss. She has double-stranded DNA antibodies. She also has a Rho antibody, and her C3, C4 are always normal. She's not responsive to hydroxychloroquine, methotrexate, mycophenolate, tofacitinib, leflunomide, or Rituxan, or belimumab, and she rolls into your clinic and her rash looks like this. And she's got this rash all over her arms, her face, her chest, her back. And she really can't drop her prednisone below 10 milligrams a day. So what do you guys think would be the best treatment option for this flare? Dapsone, sending her for UVA phototherapy, anifrolumab, or azathioprine? Okay, so you guys all voted, and this is what she looked like after treatment with anifrolumab. And the reason that I think anifrolumab was right, because when she has refractory skin disease, and we know that anifrolumab is really good at treating that, we definitely don't want to give her UV therapy because that can cause skin disease to get worse. I think Dapsone, you could add it as a reasonable option, but I think the best therapy in that list would have been anifrolumab for her. And I can't remember what the other one was in the list. Oh, azathioprine. So she'd already failed 2 anti-metabolite drugs, methotrexate and Cellcept. And so my opinion is if you're not responding to anti-metabolite drugs, you're probably not going to respond to a third one. But you could have tried it. It wouldn't have been wrong. It's in the list. But I think, again, the best drug choice, if I'd had to pick, would have been anifrolumab. And that's actually what she did quite well with. So the second patient I just wanted to go over with you. So this is a 38-year-old female with a history of lupus characterized by cardiomyopathy. And this is probably related to undiagnosed lupus that happened prior to presentation at your hospital. She gets skin hypopigmentation. She has a positive ANA at 1 to 1,280 in a speckled pattern with a positive Rho, RNP, chromatin, double-stranded DNA. She also has an inhibitor to Adams TS13 as part of her antibody panel. She has hypocomplementemia, and she is currently on MMF and Plaquenil and low-dose prednisone, and she was compliant with these meds. And she came into your clinic with worsening digital pain and color changes. And so this is what her finger looked like. So the labs showed that her previously normalized complements have dropped again. She has a high SED rate, and her double-stranded DNA antibody, which had been downtrending and almost normal, is now elevated again. She gets an echo that shows a reduced EF, and there's no thrombus on her echo. And you get an angiogram, and it looks like this. She has extensive scattered occlusions of the distal arteries of both hands, involving nearly all the digits, but worse in the left second finger. So we don't think this is just like a single embolus, because it's happening in all of the fingers. The occlusions don't respond to nitroglycerin, so there's really no vasospastic component, making something like a Raynaud's related issue less likely. And she had sort of normal looking, more proximal arteries. So in addition to adding a higher dose of steroids, what do you think would be the next best option? Methotrexate, cyclophosphamide, rituximab, or belimumab? Okay, thank you everyone for voting. So I felt in this case that the best treatment choice was actually cyclophosphamide. Based on these angiogram results and the increase in her inflammatory markers, we felt that there was probably a component of lupus vasculitis contributing to her disease. It's complicated because she has the RNP, and whether she has a scleroderma overlap. She has no scleroderma features in her skin, but it really was felt that there was a vasculitic component to this, and that would put that, vasculitis is considered a severe manifestation, especially if she's getting tissue necrosis. And, even though she has a drop in her double-stranded DNA and complements, and you could say, well, maybe belimumab would be a good choice for her. I would say because she's so severe and she's losing tissue, I wouldn't want to wait 6 months for belimumab to work. Cyclophosphamide works pretty fast. And so we chose to put her on cyclophosphamide, and she did really, really well. And she actually felt like much better on cyclophosphamide. Rituximab, I think, a lot of people like to use rituximab for vasculitis, but I think we don't know how it works in lupus vasculitis. And I would say if she didn't respond to cyclophosphamide, it would have been a reasonable thing to add. But I think at this point, cyclophosphamide would have been the first choice. And again, methotrexate, I'm not sure. It could work, it could not. But again, when we're dealing with organ-threatening manifestations, I think we go to cyclophosphamide in this case. So to conclude, I think the things I want you to take away from this talk is that lupus is really a complex disease, and it's characterized by immune activation in innate and adaptive compartments. And flares are triggered by stimuli that really are activating the innate immune system to produce inflammatory cytokines, and their job is to really turn on the adaptive immune system. Type 1 interferons are very important in lupus, and they change the whole immune system environment to really push things towards autoreactive processes. And I think the final thing is there's really no one right way to treat lupus flares. It's a smorgasbord of choices, and you really have to just think about the biology behind the disease manifestations and also understand how the drugs work in order to really try to make the best therapeutic decision for your patient. So with that, I will end my talk. Thank everyone for their attention. I'll be happy to answer questions in the Q&A.